Hi, I'm Lisa Gibbons, and like you, I'm a caregiver. If you're watching this, it means there is someone in your life who needs you now more than ever. It also means that you love that person enough to want to learn everything you can about being the best possible caregiver. This whole series was designed to support you, to ensure that you and your loved one have every shot at being successful during this time. Now, it's a tough job, there's no doubt about that. Chances are you will be tested in ways that you can't even imagine right now. Chances are you'll be rewarded in ways that you can't even imagine. This is an unselfish thing that you're doing and can be the most meaningful time of your life. Now, you're going to meet people who've been there. They understand how you feel. They're going to give you practical tips and information. Take your time with it. There's a lot to think about here. Know that at the end of the series, you will know that you can do it because you can. We want to thank all of the people who so generously opened up their homes and their hearts and told their stories so that you can feel supported and knowledgeable as you gather yourself to prepare for this journey. Alzheimer's may be the cruelest illness a family can face. My family has faced it twice. First, it claimed my grandmom, then just a few months before she died, my mother was also diagnosed with Alzheimer's. I think what makes this disease so cruel is that it works in slow motion to rob us of our loved ones right before our very eyes. As it attacks the brain, it gradually takes away their ability to remember, to take care of themselves, and even to recognize us. It takes away what makes them who they are. In addition to the emotional burden, Alzheimer's places a huge physical burden on families, as our loved ones need more and more care. For many years, it was a burden that families like mine faced pretty much alone. There weren't many resources available to help them, and many families thought that having a loved one with Alzheimer's was a source of shame. Not long after we got the news of my mother's diagnosis, Mom made me promise to help tell the world about Alzheimer's disease. That's why I'm here today. I want you to know that while there is not yet a cure for Alzheimer's, there is hope, and even more, there is help. We are not alone. As my family discovered through suffering with this disease, as millions of other American families are suffering, we can find support amid the difficult challenges of caregiving, and we can help our loved ones continue to enjoy a life with dignity and meaning. And that's what this series is all about.
Alzheimer's is the most common form of dementia. By dementia, we mean an individual is not able to understand, remember, or act appropriately. It really is a loss of cognitive abilities. And there are many causes of that, many different forms of dementia. A series of strokes can cause dementia. Sometimes vitamin deficiencies such as B12 can cause a dementia. Sometimes an individual can have a dementia after severe head injury. So many things can cause a person to lose their cognitive abilities.
If somebody has decreased cognition, it means that they do not have the capacity to understand an object, a time, a place, and that term is commonly used in people with dementia. Now, dementia comes from the Latin, which means de, without, and mentia is mind. It literally means without one's mind. It actually came out of the battlefields when the Romans saw these gentlemen come off the field, their soldiers, that had been hit in the head, and they did not have an ability to understand things.
There are many things that can cause dementia. The most common is Alzheimer's disease. Alzheimer's disease is a progressive dementia, progressive memory loss that affects short and long-term memory. It affects what we call executive function, which is carrying out complex tasks. Doesn't mean that you're a businessman necessarily, but any sort of complex task like cooking or buying groceries.
Dementia is a permanent change in memory, thinking ability, and judgment in an adult. It is not mental retardation. It does mean change from a previously higher level of thinking, memory, and ability to function. It affects language, concentration, attention, judgment, problem solving, ability to handle money, ability to make decisions. It causes real changes in the brain, but they are not visible in the person's physical functioning for quite some time.
Dementia is an impairment of a mental function of a certain severity. However, we recognize that before one gets to the level of dementia, there are stages that one can identify that we might call pre-dementia, which has been labeled mild cognitive impairment. And this is a very important stage because as we start treating different causes of dementia, including Alzheimer's disease, we identify the earliest stages of those diseases by identifying this condition called mild cognitive impairment.
Alzheimer's was actually first named in the late 1800s after Dr. Lois Alzheimer, who was a German pathologist who, in doing autopsies on individuals who were demented and who had passed away, found very unusual changes under the microscope. These are degenerations of cells in the brain that have a tangle, a neurofibrillary tangle, that is the hallmark of Alzheimer's disease.
Our brains include a remarkable communications network. Billions of tiny electrical impulses containing messages travel from one brain cell to another every second. The signals are sent by electrical and chemical neurotransmitters that allow the messages to travel across minute gaps between the neurons. Alzheimer's causes the network to break down by inhibiting the brain's production of a chemical called acetylcholine. With acetylcholine production reduced, a sticky substance called amyloid plaque forms between the neurons, limiting the normal flow of information. In addition, protein fibers within the neurons become twisted, further diminishing the process. Over time, the disease reduces the number of functional neurotransmitters, and brain cells gradually lose their ability to communicate with each other.
It's basically robbing us of the ability to remember recent events and also having difficulty remembering long-term events. It interferes with our perception of what's happening around us.
Alzheimer's is a slow, insidious onset. If people say it started on Tuesday, it's not Alzheimer's disease. There are lots of causes of acute confusional states in older people that may resolve with treatment of an underlying medical problem.
The first signs are often very difficult to identify. In fact, it takes about 2 years for a family to understand that Alzheimer's may be a process that is of concern for their loved one.
My granny made the best biscuits. And I remember as a little girl knowing something wasn't right because we were all together for Sunday dinner and Granny couldn't find the biscuits. They were in a dresser drawer in the bedroom. With Mom, it was a little different. She was repeating herself and getting lost, but more than that, it was a personality change. She loved to be around people, always this very social woman who adored children. And more she began to get agitated and uncomfortable in those situations. But it's tough because all of us experience normal forgetfulness from time to time. The early stages of Alzheimer's can be difficult even for professionals to detect. Even so, doctors today are better able than ever before to detect Alzheimer's if you know some of the symptoms to look for.
My mother early on began forgetting little things. We noticed one Thanksgiving when the whole family came down for dinner that she didn't cook enough. And that was probably the first thing that we noticed.
She just very forgetful all the time, repeat things. But we really think that's just part of aging. And we try to get some help because sometimes we don't feel that we can leave her home by herself. So went to a social worker to ask them to see what kind of assistance, home care that they can help us with. So this lady come to my house to do a home visit, And I think just took one look at my grandmother, watch her a little bit, and she handed me this pamphlet and to say, this is what I think your grandmother have. You better take her to see a doctor to get formally diagnosed.
We first had the diagnosis as a result of some of the differences in his behavior, his forgetfulness, his lack of being objective about things, and just being a sort of a different person than the one we had always known.
She was a little disheveled, maybe not eating properly, was eating a lot of sweets, and thought that the diet should be looked at. And to my surprise, I received a call from my aunt who had taken her that day, and she said, B Mama, that is the name we call my grandmother. B Mama has Alzheimer's disease. And I couldn't have been more shocked, because of all people who should have recognized it in my own family, I missed it completely.
She was so confused. I would call her on the phone and ask her what was going on, and you could make absolutely no sense of anything. She would also, at times, my father would tell us, leave the house, leave the stove on, that kind of thing. So there were clearly patterns that were going on that I and my two sisters totally ignored and said that my father was overreacting.
It started apparently with the usual symptoms, not remembering where your car is when it was parked, and some paranoia issues. They had started to notice that she was, envisioning conspiracies against her, and the usual dementia issues.
One woman came to me and she said, I'll tell you how I knew something was wrong with my mother. That her mother was only 65 years old. She was very active in her church. She was known for her cooking ability. She made cakes for every funeral, every birthday, every wedding. So one day the daughter asked, Mom, can I borrow that recipe for the Italian cream cheesecake? Now, her mother was living independently on her own in her own farmhouse. So when the daughter went back, she found 300 cards tied with a blue ribbon, numbered 1 to 300. And those 300 cards were the recipe cards she used to be able to successfully make this cake. And the first card said, get out 3 eggs. The second card said, crack them on the side of the bowl. The third one said, take the yellows from the whites. To be able to do the complex task of making this cake successfully, she was able to hide it because she used such excessive cueing to be able to do it.
First of all, it's important to say that there is such a thing as just normal forgetfulness that happens to all of us. And so if a person forgets where they put their car keys but later remembers, that's probably just normal forgetfulness. If they begin to have difficulty doing simple tasks, normal everyday things that they've done all their life, that, however, may be more of a problem. They may begin to pull back and isolate themselves a little bit, because in the early stages they recognize that something's not right, that if they go to a social gathering, they may not recognize people or be able to recall names as they once did.
My husband was a very gregarious, outgoing person, and he became withdrawn and would spend time away from the family, like go in a room by himself and not be his old interactive person that he had always been.
There's a problem in the job where you may get a call from somebody saying that your husband, your dad, your spouse is not performing the abilities that they used to, or they're going in, they're forgetting some of the things that are common things that they normally would do. And some of that can be stress, and that has to, again, it has to be ruled out that there are other reasons that people have that, but need to look at that.
Following through with activities that they have enjoyed in the past. Do they still play a musical instrument? Do they still read? Do they enjoy hobbies that they had in the past? Often this is lost with the Alzheimer's patient, and maybe some subtle first evidence that the person is losing capacity in these areas.
Often people get lost going on familiar routes. People have trouble paying bills, taking medication properly. Often people withdraw from previously enjoyed activities, sometimes because they're frustrated or they're embarrassed that they're not able to keep up the way they used to. Sometimes there's uncharacteristic suspiciousness. of people closest to them.
There were instances where he would move household items. You'd be looking for him. Things in the kitchen, for instance, Sweet and Low, and find them, almost a whole package, in his dresser drawer, or paper towels pulled off squares at a time and folded up very carefully and also put in the drawer, and just different aspects of his behavior that were unusual and not making too much sense, and yet he did not seem to have any awareness that this was unusual behavior at all.
Some people are very aware of their losses and may complain that they're not functioning like they used to, or they're worried about their memory. Some people have very little initial insight, and their symptoms are only noticed by their relatives.
There often are behavioral changes that accompany Alzheimer's disease. Some people have delusions, hallucinations, they become agitated, they have what we call problem symptoms or problem behaviors, and even psychotic types of features at times.
He said, "This is what your grandmother had, Alzheimer's disease," and we really don't understand what does that mean.
If the cognitive tests were showing that there was changes in his understanding and behavior.
Nobody really denied the fact that it was there. I think we were all very rational in terms of, we have the evidence here in terms of the report. I can remember sitting with the social workers at the end of that session going over what they had found and what they would recommend in terms of their plan. And I got very angry, actually.
In the earliest stage of the disease, when perhaps the person's living independently, having some memory problems, and someone else notices, someone else first notices, but they're still living independently, maybe still in their own job, what that person needs is a good diagnosis.
If you're concerned that your loved one may be suffering from Alzheimer's, the first step is to visit your primary care physician. No test can diagnose the disease with 100% accuracy, but the doctor can evaluate whether other physical conditions might have caused symptoms you noticed and can perform other tests that are highly reliable in detecting the presence of Alzheimer's. As a family, you have an important role to play in helping the doctor make the diagnosis.
A good diagnostic workup is primarily based on the history of the development of the symptoms. So the physician will need to speak to an informed family member who's seen this person over time and can describe how they were before versus how they're functioning now.
Alzheimer's disease is a diagnosis of exclusion. There's no test that will definitively say you have Alzheimer's disease. So families need to understand that. And what I usually describe to them is that this process is like putting together the pieces of a puzzle. And so the things that they tell us about the behaviors and the changes and the patterns they've seen are one very important piece of the puzzle, and we need them to be as specific as possible.
You have this fixation in the last 36 hours that I have taken these things from you, and I haven't.
Can I explain something to you, Ruth? Of course. Sometimes what happens is that you may put something somewhere, but because you have some loss of memory, you may forget where you've put that object.
Typical symptoms are often expressed by a spouse at the time of an office visit, and a physician might be asked to do a minded memory test of the patient. Often a spouse will ask for this, and by that time, some of our tests are very suggestive.
Now, do you recall those words that you repeated after me?
Table. The apple.
Okay, they were table, apple, penny. Repeat.
Penny. Table, apple, penny.
Try to remember those because I will ask you for those again, please. You think you could copy this design for me right here, please? I'd like you just to duplicate this design for me. And what about this?
Oh,
What's that called?
I was just taking these out of the drawer. When a kid. Shock.
Most people begin by consulting their primary care physician. Someone who has known the person over time is in the best position to assess changes in behavior and functioning. And any general internist, family doctor, or primary care clinician should know enough to do an adequate evaluation of Alzheimer's disease.
We look at any sort of medical problems they have because there are many other things that can cause a memory loss or mimic Alzheimer's disease that need to be excluded. It's important that we do that because some of these things are treatable and we may be able to improve what's going on with the patient. It may not be Alzheimer's disease.
Often patients realize something is wrong. They may be embarrassed, frustrated, and they may be reassured to know that it is not their fault. They're not going crazy. It's not that they didn't keep up with current events enough. It's not that they're not smart enough. It's not that anything that they did that caused this problem. They should be told that they have a memory problem, that it's caused by something in their brain, that it's something that we know about and there are things we can do to treat it. They should be told that they are going to need more help from their family, and they would be wise to accept that help in order to make their lives easier and more comfortable. The family should be told what to expect from this disease. It's progressive, it gets worse over time, but that doesn't mean there aren't things at each stage that the person can do and can enjoy. And the important message is that this disease changes over time. Not everyone gets the same symptoms. Not everyone has the same course. No one can tell you how long it might last. And many people function quite well in supportive, structured, routine environments for quite some time.
Well, many times families are experiencing a lot of denial because someone with this disease is usually able to cover it up for a long period of time, so they may deny actually that there's a problem. Then when they are no longer able to deny it's a problem, many times families are very much in shock that, oh, this is happening to me. And now, because of increased awareness, many people also will experience a sadness or a depression and kind of almost a sense of giving up. And some of the work of the Alzheimer's Association is to try to change that sense of, I can't do anything about this anymore, and that we can make a difference, and that even though someone has the diagnosis of Alzheimer's disease, it is not a death sentence. Very important to help families to have some tools that they're able to help one another deal with the disease.
Patient has a right to know their diagnosis. But I think we should also understand that many patients may not want to know the diagnosis. And so my own philosophy is not to force a diagnosis on them just because I feel that the patient has the right to know.
A lot of the factors that people look at for Alzheimer's have to be in accordance, in association with people that may have depression. For example, someone with depression, if you ask them what day it is, they'll say, I don't care and it doesn't matter. Someone with Alzheimer's disease, you ask them, tell me what today's date is. They may try to guess and say, well, this is the spring and this is 1953 and I just came back from a vacation to Europe. Well, none of that is correct. But in their mind, they're thinking, this is something that's important, that I can tell this person about myself and what I've done.
So I think she was sad, she was depressed, she got into the very typical things about, I want to go home, this, that, and the other thing. I only wanted to emphasize the positive and say, oh, gee, isn't it great to be out here? Come on, we could do all these kinds of things. So at that point, I think she was just depressed. she was confused, and she would say things like, "I don't know what's wrong with me." So I think that she was upset, even beyond the depression. She was upset because she didn't know what was going on, and that really tugged at me.
As I look back and reflect, she was not eating properly. Her dress, her appearance had changed significantly, wasn't really taking care of herself, bathing, grooming, dressing. It seemed to be a little more withdrawn, depressed, and that's something that after the fact we realized she had had for a number of years, that depression.
In general, the patient with Alzheimer's disease is unaware of the illness, and to some extent that is a saving grace for them. However, patients with Alzheimer's disease also tend to become depressed, and it's more common for a patient with the depressed form of Alzheimer's disease to be more aware of their impairment. I certainly wouldn't say that everybody with Alzheimer's disease is unaware of the illness. To some extent, they may not realize the extent of impairment that they have.
Actually, I guess I was the one to deal with the diagnosis because my husband, either at that time or at any time during the illness, never exhibited any apparent signs of being aware that he had this illness or that something was wrong with him.
Families don't want to confront the person with the illness in front of them in a way that diminishes them or makes them feel like they're being observed. And so they have to find a discreet way to do that. They do need some private time to talk with a physician openly about their concerns about their relative.
None of us in my family were ready for how rapidly this disease would progress with my mom. It was like 1 minute we had her. You know, the light was still on in her eyes, and then very shortly after that, the fog just rolled in and it became more difficult to find any elements of her. Whereas with my grandmother, it was a much more steady and slow decline. It's different for everybody, but typically, Alzheimer's follows a progression of 3 distinct stages: early, middle, and late. The length of each stage may vary from one person to the next, and so may the symptoms. But even so, it can be very helpful to you as a family member to know generally what you can expect to see with each stage.
She would forget things, but as she progressed further on into the disease, the deeper the memory loss became, I think, quite frankly, the easier it was for her to cope.
Well, this is my grandmother, and this picture was taken at a time when I was hardly able to get her into Penny's. She was shuffling by that point, walking in to get her picture taken. She had gotten to the point that her dementia actually worked for us, and she wasn't fighting and trying to keep it together. She had actually relaxed and enjoyed that opportunity.
So we look at Alzheimer's as having 3 general stages: an early, which can be very hard to identify at first except by individuals close to the affected person; the middle stage, where they need assistance and supervision, which can last anywhere from 2 to even up to 10 years; and a late stage, where they require almost constant personal care, which generally is fairly short, 1 or 2 years.
Other people have used other schemes, and there's a scale which is called the Global Deterioration Scale, which divides the illness into 7 different stages. Stage 1 is actually the normal stage, and stage 2 and stage 3 roughly correspond to mild cognitive impairment. Essentially what happens in these different stages of the disease as one progresses downwards is that the memory becomes increasingly impaired. It becomes impaired to the point that it starts affecting the ability to function in everyday life.
Early stage usually is up until and including the time of diagnosis.
Someone who's in the early stages of the disease really may not be aware that they're experiencing some of the problems. So, for example, they could be sitting in the middle of a classroom or in the middle of a social activity and be fully cognizant and aware of who's sitting around them, what's going on in the environment, and then all of a sudden they'll lose it for a moment, and they may become very startled and not know aware of what's going on.
In those early stages, the other things that folks need is to make decisions. They need to make decisions on, do they want a living will? Do they want advanced directives? Where do they want to live? Who do they want to have taking care of them? Do they want to designate who is going to get pieces of their property? The more you can have feelings of control of what's going to happen to your life, particularly in the stage where you know about the disease, you know you have the disease, and you can express what your needs are.
What I found with my grandmother is the first sign again is nutrition, hydration. Are they drinking? Are they eating? And then medication compliance. That's a huge problem. Our hospitals are full of those who are in because they are malnourished or have not taken their medicines. And right before the family's eyes, who are loving and caring and spend so much time with them, they miss that as we did.
As the person moves through the disease process, they'll probably still be able to live pretty independently. They will start to have problems with complex tasks, handling their checkbook, paying their bills. Those are some of the first problems. Driving a car. Actually, in this early stage, it's not actually the mechanics of driving, but it's getting lost when I'm driving, not being able to find where I am. Being able to cook, doing complex tasks of storing food, cooking food, eating enough.
But I think the beginning stages are the hardest because the individual has to be frightened. I think there were times that she was really frightened.
The person with dementia may forget that they have the disease, and emotionally they're very intact, and it's something like that social facade that we all put on. Oh, you know, when you feel miserable and someone says, "How are you today?" you go, "Oh, fine, thank you." That's still intact. So if you try to intrude upon me and say, "Mom, tell me where the insurance papers are," I might get really upset. Why are you asking? Why do you need to know where the insurance papers? Why do you think I can't handle my own bills now? So sometimes this is very difficult for the family, and it's a good time for the family to get in connection with the Alzheimer's Association.
Although some patients will develop, for example, psychosis, delusions, that, for example, somebody is having, a spouse is having an affair, or somebody is stealing from them. These kinds of things can occur in some patients in the earliest stages of the disease and may in fact be the presentation of the illness. Commonly, these problems actually occur in the more moderate stages of the disease and become more prominent as the patient becomes more advanced in the course of the illness.
During the middle stage, they begin to have more difficulty with activities of daily living. Even simple tasks begin to become more complex. Their memory worsens. They may have difficulty now recognizing family members. They may think their husband is their son or their son is their father, and really confuse those relationships, going back in their mind to an earlier time.
She had behavior that was almost compulsive, rubbing things. If she had any kind of a bruise on her skin, you couldn't stop her from scratching it. And then, of course, as the disease progressed, she became less balanced. She became incontinent.
What we have noticed is that she is starting to lose the ability to associate words with the act. Put on your seatbelt. You have to show her what the seatbelt is, and then she gets it. So that seems to be starting.
Their reality begins to shift. And it's difficult to explain, but if you've ever awakened in the morning in a strange hotel room, and when you first wake up, you're lying in bed for a few seconds and you don't know which way the bathroom is, where the light switch is, not even sure exactly where you are, but immediately it kind of comes back to you, oh yeah, I'm on vacation and I'm in a different hotel room. People with mid-stage Alzheimer's disease kind of face that all the time. Everything's a new situation. Nothing looks familiar anymore.
The final stage of Alzheimer's is very difficult. Our loved ones begin to lose the ability to function physically, and they may need round-the-clock care. Except for their physical bodies, very little of the person we've always known may remain.
Finally, the disease affects a person's ability to function in a physical way. The ability to walk changes. Patients with Alzheimer's disease become slower in their functions. They resemble, to some extent, patients with Parkinson's disease in that they tend to become stooped forward. They tend to fall more easily. They tend to have difficulty with their balance. Ultimately, the patients are unable to walk, and finally, in the later stages, they become bedridden. Swallowing becomes a problem. Control of bladder and bowel become problems. These are all in the more advanced stages of the disease.
During the late stage of Alzheimer's disease, all of these symptoms really progress. They began to lose the ability to communicate. Their sentence structure goes from being able to make complete sentences and thoughts to very simple terms. They may call objects by different names. They may struggle with finding words. And as the disease progresses through the late stage, they often lose their ability to communicate at all. They also begin to lose their ability to do other simple functions. Walking, sitting in a chair, become increasingly difficult. They may be able to do a function if you start the process for them. For example, if you put a toothbrush in their hand with toothpaste on it and bring it to their mouth and start the process, there may be enough remembered memory that's embedded in the brain that they can finish the process. But without that starting motion, they would have no clue what a toothbrush is or what you do with it, or that there's any such thing as even brushing your teeth. It even progresses to the point that they forget to swallow. That as you feed them, you literally say, chew the food, swallow the food, chew the food, swallow the food. You have to tell them even those basic things. The process is ultimately that this does become a terminal disease, and they often end up bedridden, unable to communicate, requiring total care.
Unfortunately, there is no cure for Alzheimer's today. But that doesn't mean there's nothing we can do to help our loved ones enjoy as high a quality of life as possible for as long as possible. And though we can't yet stop the disease, there are ways to slow its progress through new drug therapies, through treating other chronic conditions, and even through simple activities. In addition, there are new drugs that help stimulate the brain to produce more acetylcholine. And for the first time, there are drugs which, when used in combination with these medications, can help reduce the effects of moderate to late-stage Alzheimer's.
It's difficult to know whether the medications that are for Alzheimer's really are helping until you take them off of it. All it's really doing is slowing the progression. It's not changing anything about the current situation. It's just hopefully keeping it from progressing further.
The treatment options for Alzheimer's disease right now were very limited. First of all, there's no cure for Alzheimer's disease. There are a lot of things on the horizon. There's over 50 drugs right now that are being looked at and tested in the marketplace, in the pharmaceutical marketplace for the disease. But those aren't all out yet.
The treatment of Alzheimer's disease right now is based on a group of medications that increase the levels of a chemical messenger in the brain called acetylcholine. This is a neurotransmitter, or a chemical messenger, if you will, that is very important in the memory circuitry of the brain. The levels of this chemical decline with normal aging, but particularly with Alzheimer's disease. By boosting the levels of this chemical, we are able to improve memory function. And there is some ongoing debate on whether we actually are able to slow down the progression of the disease. having treated a lot of people who are in the stage of mild cognitive impairment, that is, they don't have dementia yet, and yet we know that they have the earliest stages of Alzheimer's disease, treating them with this group of medications that enhance acetylcholine in the brain, we seem to be able to keep them stable for many years, more than one would have expected.
One of the most effective ways to manage this illness is to treat any other existing chronic conditions that the person with Alzheimer's may have. If you can correct sensory deficits, make their hearing as good as possible, make their glasses prescription accurate, give them good dentures if they need dentures so that they can continue to eat or chew their own food, all those things make a big difference. Treating heart disease, treating hypertension to prevent strokes. We now know that the presence of strokes increases the severity of symptoms in people with Alzheimer's disease.
Well, there are some pharmaceutical treatments that are available, some interventions that are being released through the FDA. There are currently 4 of those. And of course, that continues to change as we have more and more research. It's very important that somebody who has someone with this disease stay in connection with the Alzheimer's Association so they can keep on top of those research developments and the release of new drugs. And secondly, it's very important that we work at behavioral interventions so that we give family caregivers and people who are caring for people with the disease the kind of tools and tips and techniques that can help prevent behavior problems with the disease.
Activities are also very important for the Alzheimer's victim. By engaging in activities, particularly in group activities, often the performance can be enhanced. In fact, we have information to show that by keeping the mind active, by engaging in useful, productive activities, this also can be effective in slowing the progression of Alzheimer's disease.
Now I'm looking for a little kitty cat. Miss Sarah, I think you've got one on that paper. Meow. Very good. Good job.
When do you tell others that your loved one has Alzheimer's? Do you wait so you can protect their privacy as long as you can? Do you worry that people will treat your loved one differently, even while they're still functioning fairly well most of the time? Or do you tell others right away so they can learn to relate more effectively to your loved one and provide more support for all of you as time goes on? It's a hard one. My family wrestled with all those questions, and there is no simple answer for every situation. But there are 2 rules you should always follow. First, be guided by the wishes of your loved one. And second, learn as much as you can about Alzheimer's so that when you do tell others, you can do it knowledgeably. In the long run, that will help everyone.
I have 3 daughters, and they were able to witness the behavior. It wasn't like I was telling it from a long distance standpoint. They could see for themselves the changes. And fortunately, they were all very supportive.
I didn't feel as though it was something that I had to hide. With family members, it was something that I felt I had to hide, oddly enough, with strangers.
Everybody was devastated. But I recall, I don't really know how much they understand what this disease is all about. What are they going to ready to face?
It's difficult having children that you have to explain why this grandparent is acting the way they are, largely like a small child sometimes. And I remember one time in a grocery store, the 2 of them were battling over an umbrella while I was in the checkout line, and I finally just had to snap and said, "Stop it, both of you." And I realized I have reprimanded my mother like I would a small child, but that's the way they were acting. So it's not the normal child-grandmother relationship that we have, and it has taken a lot of explaining and a lot of understanding on everyone's part.
What I have noticed is that most everybody treats Marie with respect. I mean, it's not a question of this is some person we have to hide upstairs, which I understand it was that way at one time.
Alzheimer's is a diagnosis that is recognized by almost all of us now. And children and other family members are aware and not surprised when the term is used. What they do need help with is understanding the consequences, the prognosis, the time course, and what sorts of things they can do to be of help, and what sorts of behaviors to expect from the individual who's affected by Alzheimer's.
Many of the people, in the block were aware of his situation, and they would look out for him. I can always remember one particular situation. Someone came to the door, and this was when we had gotten to the point of having to lock the door and monitor his goings and comings. Someone came to the door, a neighbor who had a new baby, and in the excitement of that, I forgot to lock the door. And within about 5 minutes, I had a telephone call. Mrs. Tucker, Mr. Tucker's just going down Forest. He's turning on 94th Street. And by the time I got outside, another was neighbor. He just went around the corner, Mrs. Tucker. So my neighbors were very supportive, and I'm very grateful for that.
In general, I would say that informing others reduces the possibility that there will be major misunderstandings that might occur, especially when inappropriate behaviors start occurring and the patient is then accused of doing something inappropriate and people don't realize that this is part of their illness.
We encourage families to be very open and honest about the disease and to let their friends know, their families know that somebody does have the disease, but it's important to arm them with information. So one of the most important things that a family member needs to do is to get information and become knowledgeable about the disease, and then they can share accurate information and accurate knowledge about the disease.
The question about how much do we tell others is kind of, once again, an individual balancing act. When there's nothing obvious to others around them, do you want to disclose information about their medical condition without their permission? That might be an important thing to ask early in the disease of the person who has Alzheimer's. How much do you want the people in the church to know? How much do you want the people in the office to know? But there will be a point that someone's going to have to know.
I think you have to determine where the child is. If it's a teenager, obviously you're going to tell them different things than if they're a 5-year-old. I think being honest with them and tell them that this is an illness, that their grandmother, for example, may not say things that make sense sometimes, that she may act differently than they remember, and that she sometimes may not even remember them, and that that's an illness making that happen.
If you think that there's a problem, or you know that there is a problem with Alzheimer's disease, then to first of all, let other family members know what's going on. Then the next step is that if those family members do not want to understand or they don't want to have it, then get information to them. We have the Alzheimer's Association, which has a wonderful wealth of knowledge and information on the internet. You can get that. It's not a disease where the family has to stay closed.
I would take her with me to the grocery store, and I would literally have to kind of hold on to her so that she wouldn't wander. Sometimes she would say things that were inappropriate, and I now know that people don't get it. People don't understand, say, oh, don't pay attention to that person over there because they have Alzheimer's. And it was, I have to say, it was kind of embarrassing to me, at the same time wanting to protect her.
This is no different than if I had a paralysis that was robbing me of my ability to walk. This is a brain disease that is robbing me of my ability to think and reason and to function. And to share that, it would be sharing the same way you would share if a person had cancer. If a person had a paralysis, you would share it with those people you would share that information with. You certainly aren't going to, hi, I have Alzheimer's, but of being able to give that information without shame. There's nothing to be ashamed of.
A person with Alzheimer's disease just doesn't experience the world the way you and I do. That's just the bottom line. Your loved one may be in the same physical space with you, but have a completely different reality going on. Living in her world of, say, 50 years ago, she may well perceive you as someone else. Or she may live in a world where simply nothing looks familiar. A closet door may look like a bathroom door. or she may not recognize her own reflection in the mirror.
But we have to try to put yourself in their place and determine, if you can, what are they thinking, or how is this making them feel, and make it as pleasant for them as you possibly can.
I just learned to try to see her world through her eyes instead of try to argue with her. And that's very easy to do for people to expect her to act normally. It took us a long time to realize that we have to see through the world through her eyes.
She's so frightened all the time because there's so much she doesn't know, and she knows she doesn't know it. That her existence is getting from moment to moment without hurting herself and without being out of my sight. As long as she knows where I am and that I'm close by, she's pretty comfortable. If I'm not there, she's agitated, which makes it real hard because you feel like you need to be there all the time.
And somehow in our minds, we come to believe that Alzheimer's is just a thing of forgetfulness. But Alzheimer's isn't just that. Alzheimer's actually attacks progressively different parts of the brain. And as it marches through those different tissues of the brain, and each of the areas of the brain have different functions. Some contain learned memory, some contain the ability to breathe and swallow. As that disease progresses, it not only erases our memories of what we've done in our life, but it erases all those things we learned, the internal list of how to go to the bathroom, of how to eat, how to cook, how to handle my checkbook, who those people are, what this object is.
In the earlier stages of Alzheimer's, we find that these patients are able to communicate better and tell us some of their fears and their experiences. In the later stages, we unfortunately cannot. We can only guess at the distress that they must be experiencing. These individuals fear the unknown, fear the loss of control, and do realize that they can't do as much as they had in the past. It's a significant loss and a period of loss that they're reacting to.
It is just a completely altered reality. When they look at their surroundings, they are not seeing things as you or I would see them. There actually are visual and spatial distortions with this disease, and how that change in reality affects them is completely individualized. And the job of the caregiver is to meet them wherever that reality is. And how you do that is really to watch them and listen to them and try to determine what their reality is. If their reality is they're living 50 years ago and they think they're a 30-year-old man and they're flirting with all the girls because they're in the Army and that's what you did, and that's their reality. And when you ask them about what's going on, they'll describe that reality of 50 years ago, not today's reality.
I might be going in a dining room and I can't remember why I'm in that dining room, and there's a sense of panic, a sick feeling that takes over that I can't understand. And what they need right there is a best friend. They need whoever is with them to become their best friend, to approach them with a smiling, happy face. Hi, oh, I'm so glad you're here. Let me show you where we're going to eat today. So it's always a pleasant, anticipatory face that says you're in a safe place.
When they talk to their daughter, who they now think is their mother, again, their reality is probably 50 or 60 years ago. And they're looking at this person who may look like their mother did when they were younger. And she was a safe person. She was someone that the person loved. And so their reality is that I'm going to latch onto you because I don't know exactly who you are, but I know you're someone that is important to me and someone that's going to help take care of me like mother did. And mother's just the common term.
Occasionally she will think that my wife is her sister. And I noticed that occasionally she does get daughters' names mixed up, but with 8 kids, I mean, I can understand that. But occasionally I think Marie reverts back to perhaps sometime in her past and approaches us like her siblings or certainly her contemporaries.
In Alzheimer's care, we talk a lot about safety, physical safety. The most important thing is emotional safety. Do I, as a person who has dementia, do I feel safe? Do I feel valued? Do I feel important here?
And she loved her home. It was everything to her. And all of a sudden, all of her, even though they were family members, coming in and doing her cooking in her kitchen and then the children, that was, I am certain, a very difficult transition. And it showed on her face that she was frustrated, that she was angry, and that she really wanted everyone to leave and wanted to return back as she always knew it.
I have tried to find something that she could still do. The last thing that she could do was fold clothes, and she can't do it any longer, just so she would have something that she felt like she was contributing. And that was helpful when she could do things, when she could pick up a dust rag and dust and those things. And I found that it was important for me to let her do those things. But she's gotten to where she doesn't know how anymore. And it has really gotten difficult for her and for me because I just don't see her happy.
Patients have what we call a frontal lobe syndrome quite often, that they become euphoric, and that's another reason why they may have very little insight into their condition. The frontal lobe is involved with control of behavior in general and certainly of insight into what's happening and also planning and future directions. So what happens in these people is that they have impaired insight into their condition as well as not remembering what they're unable to do. And so they tend not to be aware of what's going on, and they may actually be quite inappropriate in their behavior.
People stop recognizing familiar environments, and they keep looking for something familiar that identifies them and puts them in a context in place. And so they'll say, I want to go home, when they're already at home. Some families find if they just take them around the block and bring them back and say, oh, look, here's home, it's a whole new experience and they've forgotten.
There's certainly a feeling of worthlessness on her part. And it's probably aggravated by the fact that she is now taken out of her home environment, the home that she actually had in her married life and raising her children. She's certainly well aware of that. I think she accepts that on certain days. On other days, she gets into a mode where, why I don't have a home? Why don't I have my own home anymore? Who's living in my home? Those kinds of things.
Every day she said that I want to go home, and her home means Taiwan, and so we got her a ticket. My sister accompanied her to fly back to Taiwan, and on the airplane, that she watched a movie. And after the movie was over, she got up, said, okay, movie's over, let's go home. And then we realized that she didn't realize she was on the airplane. So we said, this is the airplane, and she didn't believe it. So we actually asked the captain come out to explain it to her. So she come down and sit down. Then she started getting very agitated, go up and down on the aisle. And it was very difficult because 13 hours, 15 hours flight home. And she finally, we thought, now she's been months, she's been talking about going home. So we finally took her home. And as soon as we got to Taiwan, back to the old house that supposedly she lived there for many, many years in very familiar environment. And she said, I want to go home. So when she got to Taiwan. And then we realized there's really the home to her, it's environment that she is familiar, hearing the voice that she used to hear, and the faces. Maybe she might not be recognized, but at least somewhat familiar. So it's no longer a physical place.
I have an individual she was an artist as a young woman, and then you go into her house, she has some beautiful paintings. As her disease progressed, you see her paintings getting wider and wider with less color and less types of mixtures of people in it, and distortion that occurs with it. Is it a study in how someone's brain goes as Alzheimer's? I think it could be just one individual, but I think we can look at that as an example of things become further blurred for us.
We can never entirely put ourselves inside of someone else's reality, and yet that's exactly what we're asked to do as family and friends of someone with Alzheimer's. See, the better we learn how to look at our surroundings from a different point of view, the way an individual with Alzheimer's sees it, the better we can deal with the difficult behaviors that accompany the disease. We'll look more closely at how we manage that in the next program.
The emotional aspects of caregiving can be extremely complex and uniquely personal to each individual. But in talking to caregivers, we have found they have many concerns in common. In fact, coping is the one topic that seems to be the most difficult for caregivers.
But I think as a nurse, I also feel like I should be able to do a better job of what I'm doing. And I don't mean the physical kind of things, but I mean dealing with the emotional part of the role change and the emotional part of seeing my mother declining.
To sit down and make a list of these are the things that I feel comfortable with, that I feel like I'm handling okay, and these are the areas where I'm feeling overwhelmed.
Feeling confused and pulled in several different directions is a common complaint from caregivers. Demands from work and family, plus those created from the caregiving process, may make you feel like you're not able to satisfy everyone or anyone.
I wanted to please her, and I wanted her to be happy, and I wanted her to feel well, and when I couldn't make her happy, it was just very difficult for me.
Because it's not his fault and it's nobody's fault. But you're angry because you say, why? And some days that he's more confused than others, and you lose your patience because you need a lot of patience with the disease.
People really set themselves up for physical health problems, mental health problems, when they try to do it all themselves. And it's a very dangerous position to be in because ultimately you're putting your loved one at a greater risk.
I was really becoming emotionally exhausted, was that I couldn't do the things that I love to do, and I had all this time to do it. I had all this free time to write, read, create, and I couldn't do it.
Before you can take care of someone else, you have got to take care of yourself. You have got to get up and, as much as you can, at least have that shower, get dressed, and a few minutes to yourself before you can take on the care of someone else.
Profound levels of self-care are needed in order to continue caregiving, and hard decisions like putting yourself first becomes necessary in order for you to do anything at all. And I think it's really hard for persons to make that switch and to realize that, in fact, what has all along been seen as the non-loving thing to do is now the most loving thing to do. Because if you can't maintain your own strength, then you can't be there for that person.
Whatever matters a whole lot to the individual to whom the care is given. And if it is not endangering his health, that he ought to be permitted to do it, even though the observer would think that it was stupid for him to do that it was childish or selfish or whatever. And you would think of it that he would have only some X number of years to live, and he might as well live those happily.
Fold each side of the washcloth across the palm of the hand. Now, fold the top of the cloth over the palm and tuck it under the edge. Using long, smooth strokes, wash from the wrist to the upper arm. Then bend the patient's leg on the bed and place the foot in the wash basin. Place the shampoo basin or inflatable sink under the patient's head. Using a pitcher, completely wet the patient's hair. Use warm water ranging from 105 to 110 degrees Fahrenheit. Select bedding that is lightweight, soft, and washable. Synthetic fabrics are often too hot. Starting at the head of the bed, strip the bottom sheet, draw sheet, and linen-saving pad from the unoccupied side of the bed. Roll the sheet tightly against the person's back or side. Bedridden patients should, if at all possible, be placed near a window with a view. Also place a large calendar and clock in the room. Devices like a mechanical lift can relieve much of the physical burden. First, let's learn how to safely transfer a patient from the bed to a chair. Bring your forearm to your chest, drawing the patient to you. Hold the patient's inside hand with your outer hand. This position gives you good control of the patient. Observe your home with a fresh eye for obvious dangers. You may also want to purchase a waterproof bench or chair to place in the shower or tub so the patient can sit while bathing. Always speak to the patient as an adult in a clear and respectful manner. Also, talk to the patient as if you expect a response. Many patients can understand what you're saying, even if they don't respond.
I think everyone should have a list of all the medications they're taking, what is prescribed by the doctor, have the trade name, have the generic name written down.
Number 2, when supervising or administering medication, check for the 5 rights: the right medicine, the right dosage, the right time, the right route, and the right way.
One of the most important things that a caregiver can do, or any patient can do, is be familiar with your medicine, with what it looks like.
Single, most effective way to prevent infection is as close as your sink. It's called hand washing, while turning the glove inside out. With the inside out glove protecting your fingertips, peel off the remaining glove, turning it inside out and encasing the first glove. Always use disposable gloves when touching soiled linens, pads, wound dressings, or clothing. Nutrition plays a vital part in maintaining good health and preventing and treating disease. However, most caregivers soon realize that ensuring adequate nutrition for the patient can be somewhat challenging.
More often than not, families postpone the decision to look at long-term care until their loved one experiences a crisis or can no longer take care of themselves. But the best time to explore your choices is well before you're forced to make them.
I cannot emphasize enough the kind of communication in which we learn the wishes of the individual for whom we're caring.
There are a number of warning signs you can watch for. One term you'll hear frequently is ADLs, activities of daily living.
Another trigger may be that there is particular, what we would classify as bizarre behavior.
The children are in denial that dad needs help or mom needs help. And most of those classic examples are usually people that have memory loss and Alzheimer's type dementia.
It's important to have that assessed and not just assume that they're getting old and so their memory's not good. That is not true.
We're all bounded by limits from the standpoint that even though we see need, even though that we see unmet need, that we may have to start not with level of care change, but start at a lower level with what a parent will accept.
Determining which option is best for you depends on several factors. First and foremost, the extent of your loved one's physical needs and abilities, your family's financial situation, and your loved one's preferences and your own.
The good news is that families have lots of options today. The bad news is that there's often some confusion on what those options really are.
Simple medication instruction, teaching families what are some of the side effects of medications, what are the usual schedules for medication.
There are a lot of devices that help people still continue to use their hands that have aged and aren't as strong as they used to be.
There is no shame in looking for other settings and other relationships.
Talk to your loved one in a respectful way that makes them feel part of the decision.
If you and I were uprooted in the midst of having medical problems from a home that had many memories that our children grew up in, or that we had very special things that to us were a part of our memory and history, and all of a sudden we were plopped somewhere else, it would be a catastrophic kind of reaction in a grief.
If you are truly at a place where you can no longer provide the best care for that person, you're making the most kind, loving, and ethical decision to go on to the next step. And your responsibility there doesn't end, but it changes.
Many times you hear about guilt on the children's side of things when they move someone to assisted living, but a lot of times the resident also had guilt by feeling like they may have been a burden. The biggest difference between independent living and assisted living would be someone that might be ready to make a change. Maybe the water heater's gone out for the last time. There's quite a few widows and widowers that, especially the widowers, that were not accustomed to cooking for themselves all the time, and just like the support services.
And the biggest word of advice we have for couples, a husband and wife, that are looking to move out of their home and into some type of a community.
In an assisted living community, residents receive the help they require with activities of daily living.
Aging in place assumes that we build in the support that's needed in an appropriate fashion as conditions and as the aging process itself present opportunities to make life better for that individual.
There are two levels of nursing care, and many facilities offer both. Skilled nursing care.
Be very picky. Be very picky. It's very difficult to make that first move. It's even going to be more difficult to make the second move.
But it's also important to go at some unscheduled times because you want to see what's going on in the evenings or what's going on the weekends, because typically staffing patterns are different.
There is no substitute for a loving, trustworthy, empathic individual.
How they structure their day, what kind of activities they have, what kind of staffing ratios they have. Do they have a nurse on site? How do they handle emergencies?
At the same time, they want the CNAs in the facilities to realize who they're dealing with, that this is your husband, and he was a banker, and he loved to ski, and to humanize your loved one.
The pharmacies usually will package it in what they call bubble packs, and to find out maybe they cannot swallow certain types of pills or certain capsules, or can they be opened up and put into Jell-O or to applesauce. If that's what was done before at home, then maybe that's what you need to be able to emphasize also to the people at the facility.
They still know their family member better than anyone else, and that in fact it is their responsibility to maintain an alliance and a partnership with a care facility.
Nursing homes are the most highly regulated healthcare industry in this country, and they have very stringent requirements related to that. However, that does not always translate to high-quality care.
They need to be very bold and very specific in knowing what's going on in an environment where a loved one is placed.
Many Americans are looking at long-term care insurance as a way to preserve choice, protect their assets, and reduce the burden for family caregivers if the need for care arises. Medicaid is a joint federal-state health financing program for low-income individuals.
Depending on a person's age and their sex, their health, they may live many, many years needing some type, if not complete, long-term care. So having that insurance policy for peace of mind, if nothing else, for many people is quite helpful. Many children are beginning to look into long-term care policies for the same reason.
Some people think that buying long-term care insurance can be quite complicated, when in essence there's basically 5 decisions that you're going to make.
It's important to have a comprehensive policy that offers benefits across the care continuum, meaning home health, other community care such as adult daycare, assisted living, skilled nursing facility, who knows what will come in the future, whatever the continuum is, so that the person has choices, because really the crux of long-term care insurance is asset protection and independence and choice.
Then that policy is going to allow their caregiver at home to have help come in on a regular basis to give them the relief they need to provide care for that individual for a longer, more extended period of time.
There are 3 important legal instruments that address these issues: a testamentary will, a living will, and a durable power of attorney.
Now, in almost every state, even if there's no will, the property is going to pass to the spouse and then the children. It won't go to the state, which is what a lot of people are afraid of. Oh, if I die without a will, it's all going to go to the state. Property only goes to the state.
The living will is really a communication device to your family and to your providers, healthcare providers, your doctors and others. These are my wishes. I'm writing this down and putting it in a form that I want you to respect.
80% of people who die in America die in the hospital. Many of those deaths occur in intensive care units. Some of those deaths, about 15% of them, occur after the patient their heart has stopped and we've attempted to resuscitate them.
A durable power of attorney is another important means of making sure your wishes are followed.
A durable power of attorney for health care is another legal instrument that allows a person, whether they're terminally ill or well, to identify another person.
It is a good idea for people to have the living will, the durable power of attorney for health care, and the general or financial power of attorney to cover all financial matters.
Generally speaking, when people get to the place where they have to make decisions about long-term care, financial decisions are the last thing that they want to be dealing with.
It's almost a skeleton binder that the parent or the child can have as a starting point to say, I've got to find this document, I've got to find this document, and it's a place to where you can store everything.
You don't immediately assume that what you're looking at is simply a document. It may actually be the asset itself.
How much will you need to spend? To answer this second question, you'll need to do a little legwork.
What most people end up dealing with is, how do I make my money stretch far enough?
For most of us, Social Security is the first financial resource we think of when we plan for our retirement years. But the benefits are not the same for everyone, and not everyone qualifies to receive them.
The spouses may want to check and see whether it would be more beneficial to draw their normal Social Security benefit.
In the distribution phase of a retirement plan, you really have to be aware of the income tax associated with each retirement account. The money that is set up for the fixed income side is set up in a way that you have a consistent flow of income, whether on a monthly or a quarterly basis, to where you can keep up with the inflows.
Part A pays for hospital care, a limited amount of nurse. Medicare Part B pays primarily for physician charges, though it also covers. Medicare benefits are based on a complex table of charges that the government believes are reasonable.
When a physician accepts assignment under Medicare Part B, they are accepting the Medicare-approved charge as payment in full. But a Medicare summary of coverage basically gives you an explanation of what charges the doctor has charged based on the given. In addition to traditional Medicare, the federal government has created Medicare Choice.
Since Medicare doesn't pay for everything, many people buy supplemental coverage.
In the early 90s, the federal government standardized those plans, and there's now 10 plans.